year's title is Racism as a Public Health Crisis. And there with my notes, I'll read from here. Racism, the Black community, and lung health. My name is Felicia Fuller, and I'm the Director of Lung Health Promotions in the Chicago office of the American Lung Association. Myself and my esteemed colleagues, Molly Collins and Candace Alexander, will guide you through this journey over the next hour as part of our DEI Black History Month activities. I am pleased also to be joined by two wonderful experts, Lilliann Paine and Dr. Ozuru Ukoha, that will share their knowledge and expertise on this critical subject. Please enter your questions in the chat box, and we will get to as many as we can by the end of the segment. But before we jump into our panel discussion, I would like to welcome Cheryl Calhoun, National Board of Directors, Chair-elect, for some opening remarks. Cheryl?
Thank you, Felicia. Hello, everyone, and thank you for joining us for the American Lung Association's webinar, Racism as a Public Health Crisis, the Black Community, and Lung Health. As the nation's oldest voluntary public health organization, the American Lung Association has an extensive history of health promotion and advocacy work to reduce health disparities, both raising awareness of disparities and taking action to address them. In our work to improve the lung health of Americans, we want to reach all Americans, but especially those most vulnerable. As you may know, beginning in 2020 across the country, elected leaders have been passing resolutions declaring racism a public health crisis. According to the American Public Health Association, there have been 231 declarations at local, county, and state levels. Milwaukee County was the first place in the country to make a declaration, and we will hear from one of the key individuals behind that work, Lilliann Paine. We will also hear from Dr. Ozuru Ukoha, who will speak to the clinical implications of these types of declarations and how these declarations must be followed with action. Next slide, please. This webinar is part of a series of events and resources we are highlighting in honor of Black History Month. The month of February is a time to celebrate the significant contributions Black Americans have made throughout history and engage in meaningful conversation about how to continue down the path toward a more equitable society. Led by the Lung Association's National Diversity, Equity, and Inclusion Council, we have several special features focused on the Black community that we encourage you to explore on our website at lung.org. Now I'd like to turn it back to Felicia Fuller to get this conversation started.
Thank you, Cheryl. So as any good health professional knows, we always start with statistics. So we thought we'd start at least with discussing with you a couple of lung health disparities. We'll start with lung cancer, and Dr. Ukoha will go over some of these again later in our conversation. Black Americans were 18% less likely to be diagnosed early, 23% less likely to receive surgical treatment, 9% more likely not to receive any treatment, and 21% less likely to survive 5 years compared to their white counterparts. Black people in general, but specifically Black men, have the highest rates of lung cancer in the US and likely to die from lung cancer. Asthma, let's talk about that for a minute. The asthma death rate was 2.8 times greater among Black Americans than white Americans. Black Americans are generally more likely than other races and ethnicities to be diagnosed with asthma over their lifetime, having the second highest lifetime prevalence rate of approximately 16%. Black Americans and indigenous communities have the highest current asthma rates compared to other races and ethnicities. Tobacco use. 81% of Black smokers, let's say that again, of all Black people that smoke, 81% of them, the usual cigarette is menthol, over twice the rate among white smokers. As many of us know probably on this call, the menthol in cigarettes has been found to make it both easier to start smoking and harder to quit. And last but not least, air pollution. The most recent EPA review of research on health effects of particle pollution concluded that non-white populations, especially Black Americans, face higher risk of particle pollution. And then probably many of us on this call can think of communities that have been affected by pollution. Most of the time, Black and brown communities. Recent studies have found those who live in predominantly Black communities suffered greater risk of premature death from particle pollution than those who live in communities that are predominantly white. Just a few. There's many, many health disparities that we can discuss, but we'll let our conversation go from there as we start our discussion. But another foundation that we wanted to set before we started this conversation was a definition of racism. There are many, many out there, and as we met as a group, we decided on these two. Racism, the American Public Health Association's national campaign against racism asserts that racism is two things: a social system with multiple dimensions, individual racism, internalized and interpersonal, and systemic racism, institutional or structural. It's also a system of structuring opportunity and assigning value based on social interpretation of how someone looks. Okay. Systemic racism, very, very key to what we'll be discussing today as well. A combination of systems, institutions, and factors that advantage white people and cause widespread harm and disadvantages in access and opportunity for people of color, including health outcomes. One person or even one group of people did not create systematic or systemic racism. Rather, it's grounded, sadly, in our history of laws and institutions which were created on a foundation of white supremacy. I think if we all kind of internalize this information before we have this conversation, it will lead us in the right direction as we discuss these matters in regards to public health and the Black community. Now I will give it to my illustrious colleague, Molly Collins, who will introduce herself and also introduce our wonderful speakers. Molly.
Thank you so much, Felicia. I'm Molly Collins. I'm the Advocacy Director for the American Lung Association in Wisconsin and South Dakota. And I am so pleased to be joined today by these amazing thinkers in this area. I'm going to introduce Dr. Ukoha first. He was born and raised in Nigeria, immigrating to the United States after high school on a scholarship. He graduated from the University of Missouri, Kansas City, and worked as a registered pharmacist for 5 years to save enough money to support himself through medical school, where he was awarded the Student National Medical Association Outstanding Achievement Award. Before joining the Rush University Cook County Hospital Cardiovascular Surgery Program in 2001, Dr. Ukoha had a fellowship at Yale University. The bulk of his clinical practice has been at the John H. Stroger Jr. Hospital of Cook County as a general thoracic surgeon. Dr. Ukoha is passionate about what he does and considers it a labor of love and a privilege to give back to the community. In the last 20 years, he has won the Penfield Faber Teaching Award in Cardiothoracic Surgery, served as president of the medical staff of Stroger Hospital, was appointed the division chair of Cardiothoracic Surgery, and is the chair of the DEI Committee of the Medical Staff. Dr. Ukoha holds the rank of Assistant Professor of Surgery at Rush University. Our other esteemed speaker today is Lilliann Paine. Lilliann is currently the Director for Technical Assistance for the National Birth Equity Collaborative. She was formerly the Chief of Staff with the City of Milwaukee Health Department, where she coordinated the COVID-19 response and positioned Milwaukee and Wisconsin as innovation leaders in tracking pandemic data. Ms. Paine was instrumental in authoring the Wisconsin Public Health Association 2018 Racism is a Public Health Crisis Resolution. She facilitated the resolution's adoption in Milwaukee, which was the first municipality to do so. She currently holds a record for the WPHA presidential citations for these outstanding contributions. Ms. Paine is an appointed member of the Governor's Health Equity Council here in Wisconsin, and the YWCA of Southeastern Wisconsin awarded her the Face of the Future for Public Health in 2020, and the Milwaukee Business Times inducted her into the inaugural cohort for notable alumni in 2021. Lilliann, we are going to start with you today. Why is racism a public health crisis?
Thank you for having me today. Can everyone hear me? Great. So my academic training is in public health, and my public health experience has a foundation in community building. And from 2017 to 2019, I was the at-large director for the Wisconsin Public Health Association. So in May of 2018, when that resolution passed, the resolution's definition of crisis was defined as a problem that must affect a large number of people, threatens health over the long term, and requires the adoption of a large-scale solution. And the reference for that definition of crisis, in the sense of racism as a public health crisis, comes from Dr. Sandro Galea, who is the dean of the Boston University School of Public Health. And it's within the definition. Racism saps the energy of all peoples, and especially those most impacted by it.
Thank you. Dr. Ukoha, you shared this slide, so I'll pop that up here for you. And please talk about why you feel like racism is a public health crisis.
So if you take a look at this slide and all the reasons why Black people are more likely to suffer any of these conditions, I think it's important to look at all of this because at every rung of the ladder of life, from infancy, when we talk about infant mortality and maternal health, through adolescence, where the young men and women are tussling with law enforcement, getting thrown into jail or outrightly killed. And remember, when you kill them at that age, which we've all experienced or seen, you're ending their life prematurely. So it doesn't matter whether you die by violence or you die by healthcare-related issues. It's still premature death. And you take this group of people through adolescence into middle age, where frustrations and despair set in because obviously they're having issues with families and career and occupation, and how those get expressed. So either they smoke or they drink or they go into substance abuse, and before you know it, they set the stage for disease processes that may become chronic when they get older. So when they get older, helplessness comes full circle. And now we are treating these people that have found a way to shepherd themselves through life into the point where they are the ones with all these chronic illnesses, hypertension, diabetes, stroke, renal problem, heart disease. So, you can see clearly why, racism, which is defined by the track through life, becomes a crisis at this stage when they reach that stage. So, crisis is a problem that requires immediate attention. Okay, it is also a problem that if you don't attend to it, will lead to catastrophic results. And we learned that lesson in a tough, hard way the past 2 years. So this is why racism is a public health crisis and really needs our attention.
Thank you. Lilliann, going back to you, can you talk about how racism shows up in your work?
I think you have a slide for that. So when asked that question, I was thinking in terms of public health. And I think the work of public health, the legacy of public health. And the Robert Wood Johnson Foundation has done a great job of creating language regarding social determinants of health. So where we live, learn, work, play, and pray, and how all of that influences our health. The slide that you see now has an image from the Kaiser Family Foundation, and it illustrates how racism and discrimination shows up where we live, work, learn, play, and pray, and is compounding the impacts of those social determinants of health. So that's looking at the social and economic factors that determine health outcomes as described by the previous slide: mortality, health outcomes and morbidity, life expectancy, healthcare costs, health status, and functional limitations. Functional limitations in the sense of one cannot perform routine daily activities, or that their self-care is limited in respect to their ability to work or find employment. And that's how it shows up.
Dr. Ukoha, do you have anything to add about how racism shows up in your work?
Yes, I do. I work in a hospital, so it is just good to mention that when you as a clinician adopts one strategy fits all for your patients, you miss out on some of the other things that might be necessary to fully convey the needs of the patient to them. There is no doubt that the Black population are patients who need more attention. They carry more baggage than other patients. They're the ones who are less able to understand, what you're actually trying to teach them or show them, because they don't have the educational background to grasp it. They're the ones with the socioeconomic issues, financial problems. And so if you just put on your empathy hat for 1 second and realize that if that patient walks out of your office, having not understood anything you said, but just sat through it, you have done a disservice to that patient. So we cannot use a one treatment plan fits all for all the patients. So that's how racism manifests at work, if you don't comprehend that. Now, just 1 second about insurance. Remember, they are the ones with the low-level insurance, the Medicaid, the Medicare, the HMO that nobody wants. It's not unusual for you to show up at a hospital and they ask you, before even trying to find out what your problem is, they ask you, what kind of insurance do you have? And once you give any of these 3 insurance plans, you are done, okay? They may not accept you. So the only place where they will do that is in the emergency room, okay? So having the wrong type of insurance is another way that racism manifests itself in the workplace. Unconscious bias, judging a patient that you see based on what you see, not what you actually know about the patient, is unconscious bias. Okay, that's another form of racism. So it's clearly the areas that we have to work hard, trying to fix. And so that's the connection between our community and the medical institutions where these patients eventually end up.
Let's dig into that a little bit more deeply. Let's talk about how we can meaningfully address the health disparities that we're seeing in lung health issues and elsewhere, Dr. Ukoha. And I know you gave me a couple of slides, so I'm gonna, there we go.
Okay, so at the risk of sounding redundant, because the audience has seen this from Ms. Fuller's slide, but I just picked the 3 most common cancers that we have, and the reference point is right there. So breast, 284,000 versus 44,000 deaths. Prostate, 249,000 versus 34,000 deaths. And lung cancer, 238,000 versus 132,000 deaths. So you're talking about more than 50% of patients with lung cancer die in the year that they contracted. For prostate, it's about 13.9%. And for breast, about 15%. Okay, so it's really unimaginable. It's so staggering that it begs for action. Okay, so I mentioned right there that it's the leading cause of death in the United States. That's no surprise to anyone. The 5-year survival is still very abysmal, 20%. It just barely crawled into 20%. It's been 15% for many, many decades. And smoking is the leading cause of this disease. So I guess you can say to yourself, if smoking is the cause of this problem, why are we having such a difficulty with it? Why can't we eradicate smoking? Well, in order for us to address lung cancer, we cannot just look at the outcome. We cannot look at the result of smoking. We have to go back and find a way to prevent smoking. So that's part of the strategy that should be adopted in addressing lung cancer. The next slide, please. So when you're talking about lung health, okay, it's not just cancer. Ms. Full already mentioned the impact of asthma on the community. I just put that in there, to remind everyone that, asthma is really a big deal. And allergic asthma is the most common one, all right? So now if you imagine what happens with the insurance plans, as I mentioned before, there is no doubt that the white population will prefer to live in the affluent neighborhoods, okay, away from the Black population, because segregation actually helps improve the quality of life that they lead, okay? That's the perception, okay? Now, when they leave those neighborhoods, okay, and where their integration into it forces the industries or the healthcare system to actually, address the needs of the population. When they do that, the doctors and the healthcare institutions follow them to these affluent neighborhoods because they're the ones that have the private insurance. Okay, and so people leave these neighborhoods that need help the most, which is a paradox. Okay, so it's reported that between 1970 and 2010, more than half of hospitals closed in about 52 of the major cities in the United States. And most of those were small, mid-sized hospitals in impoverished urban communities. Now, when you leave them there, just imagine what you expect to happen. Okay. Now, this segregation that we're talking about has led to Black neighborhoods with the homes almost stacked on top of each other. There is no green space. There is no recreational facilities, to speak of. And so it burdens the system, and then you wonder why allergic asthma, is a problem. Okay, so I just wanted to bring that all the way around so you can understand how sometimes our actions or inactions lead us to a point or a place where we shouldn't be in the first place. Okay, and chronic obstructive pulmonary disease, COPD, is the third leading cause of death in the United States, and Black Americans own that too. So when you think about lung health, it's not just cancer or asthma or COPD. We combined, you can see what a tremendous burden this is to the African American community, and this is why we need to tackle this problem.
Thank you for all of that. Lilliann, we've been doing a good job at sort of outlining the problem of racism as a public health crisis. I'd love to ask you to talk more about how policymakers can do more to resource this fight, because obviously a declaration is just words, which is meaningful, but like we need action behind that as well. And before you answer the question, I want to invite the audience to use the two bubbles that look like little speech bubbles up at the top to insert any of your own questions into the conversation.
Would you like me to wait for the bubbles?
Oh, no, please go right
Okay.
ahead. I just wanted to make sure people knew how to ask a question if they had one.
Okay. I want to lift up a manuscript that the Campaign Against Racism invited me to participate in, entitled Declaring Racism a Public Health Crisis in the United States. Is it a cure, a poison, or both? And you can find that article in Frontiers in Public Health under the Public Health Policy arm. We walk through the origin story of the resolution starting in 2018 with WPHA, and then we examine 3 of those declarations across the United States, one of them being Milwaukee. And after Milwaukee declared racism a public health crisis in 2019, in May of 2020, the Milwaukee counties created an ordinance, Chapter 108. That's a municipal code. And under that municipal code, it was helping to look at how to examine racial equity and advance racial equity in policy. So that code helped to mandate training of staff around what is racism, how racism shows up, what does racism mean in the sense of day-to-day work for county staff, and then that led to the county becoming members of the Governance Alliance for Racial Equity. And by being members, they got support to utilize the GARE's racial equity budget tool and help to create a more equitable budget during that year. So using Milwaukee as an example, policymakers can do more by being actionable. So declaring racism a public health crisis, for example, following Milwaukee, being financially responsible. So having a budget, utilizing the racial equity tool from the Government's Alliance for Race Equity, and addressing social determinants of equity. So any legislation or policy or HR culture, framing those interventions and programs around structural racism and root causes. And then a participatory budget, allowing the community and Milwaukee County to react and respond to the budget and being a part of it from the beginning of it to the voting on it and then implementing it.
I'd like to add just a couple of things about policymakers how to resource this fight. Now, I work in a safety net hospital, one of the oldest and most renowned in the country, Cook County Hospital. The mission statement of this hospital is taking care of patients regardless of any background or ability to pay or what have you. So patients can walk in here and get taken care of. It's been going on for years, okay? Now, it is a losing proposition. You know, I was medical staff president for 4 years. So I got to look inside a little bit and I realized, you know, what a challenge it is to take care of patients like these, okay? Someone has to be able to pay or help pay for their health care. The hospitals are running away from the neighborhoods because they can't survive. The doctors are leaving with them because you can't spend your career taking care of patients with low-level insurance, okay? So what can lawmakers do? Maybe they can help match the reimbursement of private entities, okay? That's at least one way that people can stop running away from this insurance and people stop asking these questions, whether you have Medicare or Medicaid or HMO, because the reimbursement is comparable. Okay, so that's one thing. Now, you know, all of us have listened to politics for the past several years, and we've heard, you know, Bernie Sanders and some others talk about, you know, healthcare for all. Now, we know among all of us that the number one determinant of health, okay, is access to primary care. If you don't have insurance, you cannot get that access. You'll be lucky to just go and do self-pay. If you are not employed, how can you? So when you listen to people talk about healthcare for all, I just want you to drop down a little bit and pay a little bit more attention because they might be telling you something, okay? because we cannot be in this fight if we cannot arm the people with the tools they need to get the health care that is required for them. So don't be so dismissive, okay? We keep saying we cannot afford it. I'm telling this audience, we did not think we could afford COVID, right? But COVID came, and what happened? We blew up the bank, okay? Because we knew we had to. Healthcare sometimes is in that arena where you do have to do some courageous things to make sure that you care for the people who actually need you the most. Now, Affordable Care Act, you heard about it, you saw it happen. I work in a safety net hospital. I can tell you, okay, that was God sent, okay, because there were so many people who were just marginal, okay, who used that Affordable Care Act to get the health care that they've been requiring for years and couldn't get to. Okay, so you can say all you want about it because you were probably not exposed to the salient features of Affordable Care. I'm telling you, okay, that it did tremendous work for the people. Obviously, your state would have had to expand their Medicaid program to accommodate these people. But it's important to realize that, you know, it played a role. It almost died, right? Affordable Care Act almost died in Congress thanks to the strength and wherewithal of one individual. Okay, so these are the things that policymakers can do to help us resource this fight.
Thank you both for those very concrete and actionable steps that some policymakers can take. I'm going to go now to one of our other wonderful team members, Reggie Kundwani, to help with the Q&A from the audience. Reggie, are there any questions from the audience at this time?
Yes, I'm seeing one. So this question, I'll just read it word for word. So in dealing with lung cancer for Black Americans, generally with lung issues and suspicion of lung cancer, low dose CT scans are not usually done for Black Americans, especially women. Would it not be easier to have low dose CT scans more accessible to Black Americans? How do we make them more accessible, especially since lung cancer is typically diagnosed in later stages?
Dr. Ukoha, do you want to take?
Yes. Okay, let me just give one little bit of history about lung cancer screening program. Okay, the National Lung Cancer Screening Trial, which is what we're working off of on right now to address, you know, early stage lung cancer. Sadly enough, you know, did not include, you know, enough minority population. Okay, 24,000 whites, 1,000 Black, maybe less than 1,000 Asians and Hispanics. So, and all those patients, not many of them had comorbidities, which is what, you know, our community is full of. So, but we're still making decisions off of the result of that trial. And, you know, thankfully, okay, the criteria has been broadened a little bit, you know, dropped down to 50 to 80 years age range instead of 55 to 75. And, you know, allowed smoking to be 20 years, not 30. Is still 15 years prior or actively smoking. But we know that lung cancer, okay, the Black population is susceptible to lung cancer, even when they smoke less and for a shorter period of time. So as we open this up and try to recruit them into lung cancer screening programs, I bet you there's a lot more tweaking to come from, you know, which criteria we'll be using to screen people. Right now, you know, to screen somebody, the person has to have a primary care doctor, okay, or be a patient and institution. You ask all these right questions, you know, and they meet the criteria for screening. And if you have it in your facility, you just order it and it gets screened and followed up. So again, we go back to access to healthcare, right, which is the last topic. And I keep saying that if you provide people with access to healthcare, they're going to show up in the doctor's office. They're going to find out that they've been smoking and they fall in that category, and they're going to get screened. If they don't have access to healthcare, they're not going to get screened because they're not there in the first place. They didn't show up for the dance, so they cannot get screened. Okay, so unless we take ourselves into the neighborhood and actually, approach them there where they reside, either with health fairs, go through the churches, community outreach, and and try to recruit them to understand this. That's one thing that we can do, but ultimately they will have to end up somewhere. They will have to have the insurance to be able to go somewhere and get screened. So nobody's is building a roadblock preventing people from getting screened. There's just that the criteria required to get screened, they're just not there. And we would have to be more creative.
I would just like to add that with the information you've provided and your emphasization on access, there's historical context there. So just when we think of education, we have to think of literacy, we have to think of language, we have to think of cultural linguistics when it comes to care and respectful care, so that people feel psychologically safe to disclose what they are experiencing. And if they may not have an education beyond a certain level or read at a certain level, we can create access all we want. It won't be utilized, and it won't create community engagement or a system of support. So I just want to emphasize that cultural context with the language I'm hearing about right access and good access and those people not accessing. There's historical context there that speaks to the legacy of racism within education and healthcare systems.
Yeah, so before we leave this portion, I just want to emphasize that wherever you are, whatever you're doing or working at, do realize that, yes, we need to have the Black population screened. And if you can find a way to make that happen, then please do, because of all these barriers that make it difficult for them to get to be screened. And for the medical community, we have to be more creative to get them screened. And I'm sure we'll get there.
Thank you both for this really engaging conversation. I'm going to pass it along now to my colleague Felicia, who's going to take us through the next set of questions.
You are on mute.
Felicia, you're, no, sorry.
Can you hear me now?
Yes.
Yeah.
Okay. That was a very engaging conversation. Thank you both for doing that. I want to bring it back to Lilliann and talk about the Milwaukee Declaration just a little bit more. It's extremely intriguing to me. I'm so happy you were able to do it on, I guess that was a countywide, not city, countywide level. I'm envisioning, of course, maybe statewide for progressive states that maybe can take on something like this, but I'm sure it would be a very heavy pull. But particularly, I know in a lot of the work that we do here at the ALA, we are always engaging with partners, local partners, statewide partners, national partners. Very, very important to push programs and thought processes and everything that we do across the finish line. So can you tell us a little bit about the partners that were involved in the work that you did with the Milwaukee Declaration?
Thank you. And I'll try to be as straightforward as possible, continuing in that same energy that I've been responding to questions. I just want to emphasize, because this is sometimes lost when people talk about declaring racism a public health crisis. Leadership matters. And if your leadership does not represent the audience or patient demographic that you are seeking to improve health outcomes from, it won't land well, or it'll come off as being performative. And unfortunately, in some cases, that is what declaring racism a public health crisis has looked like. And it started as a resolution for the largest and most recognized membership-based association for public health in Wisconsin. I could not have imagined it would expand it to local government, state government, federal government, but at the time, the primary audience were public health leaders in Milwaukee who influenced how policy was developed at the local and state level. So working as a UW Extension educator and serving on the board of directors at the same time, my primary audience was Milwaukee County. With the membership-based organization being state, it just happened to be state. And the year following, I'm sorry, is there a question or reaction to that? I just want to pause.
No,
Okay, so the year following that, when you think of UW Extension and who your bosses are, your leaders are, it's usually the county supervisors or that executive leadership outside of the academic institution. And at the time, the county executive was Chris Abele, and his chief of staff, Riza Colton, and the director of the Office of African American Affairs, Nicole Brookshire, consulted with me after they received a copy of the resolution. The words, not that it was associated with WPHA, but the words of the resolution. And that's how I got involved in helping them fulfill that vision to the degree that it's been fulfilled. And when they rectified WPHA's resolution, the same happened at the city level. So city government and the health commissioner at the time, Dr. Jeanette Kwolek, worked closely with the director of Office of African American Affairs to make that happen at the city level with the city council. And there are their version of the origin story that you can find in articles and actual recordings of videos that speak to how aldermen responded to this being brought to them, and this I call it what it is, willful ignorance that racism exists here. Really, what does that mean? And then just as we've shown on the slides to the point in this presentation of the disparities, and then choosing language that is strong, describing without a doubt how racism threatens everyone's health and limits the life of those that are Black, Indigenous, Southeast Asian, Pacific Islander, and Latino populations. So it was very much like an inside-outside strategy. I was a member of Milwaukee County as a educator, and then a citizen in the city, and then had a leadership role within WPHA. So relationships matter.
yes, they do. They do. They do. They can help you slide through the process, or they can bring barriers, which I think is our next question, Molly. There's always barriers in everything we do, especially sometimes as women, people of color, certain people of certain ages. I'm raising 2 African-American young Black boys. I see barriers in their way consistently in all ways in life. So can you tell us some of the resistance that you did meet as you tried to implement this policy?
Yes, and I feel like my life's journey prepared me for that moment. I was a recipient of the Chapter 220 program, which was a program that integrated schools in the suburbs with people of color like myself, and had to navigate what it was like to be Black and a young person and someone that identifies as was a girl and now a woman, and what that meant to be in white spaces and finding my voice and being seen and heard and listened to and trusted. I felt the same way about being part of the Wisconsin Public Health Association. As an undergrad, it felt very familiar. Like, I don't feel seen, I don't feel trusted, I don't feel like there's a voice here for the concerns I have about my community and the concerns that I've experienced being bused out to school and being part of safety net health programs. A lot of the resistance that was alluded to as, again, we presented the disparity data. So when in a position of power to influence how we do the work, how we create a mission, vision, work plan, and then a standard to collect baseline data to judge whether or not we really are doing systems change work. So The resistance I experienced even before getting to the resolution was being a part of the executive committee and the appeasement of language. That's the barrier. So folks getting stuck on words like racism and crisis. And so a semantic battle, and then unconscious bias coupled with white fragility, because the majority of the diversity in Wisconsin is in Milwaukee, and everywhere else it's not. And those in leadership roles are from a certain generation. And when we think about leadership, I think I come from a generation where your job is not your identity. And previous generations before it, I think, lean into that and expect a certain level of respect in the form of not asking for accountability or challenging how one thinks when it comes to a decision-making process. So folks were very much paralyzed in thinking about racism and only focusing on interpersonal instead of institutional and structural change. So I've had leaders that have highlighted their language. The prophetic voice is counterproductive. And an example of prophetic voice is calling out hypocrisies in others, sharing deep analysis of racial power, and confronting people with hard truths of racism and how it harms everyone, but especially Black and Indigenous populations. And yeah, flashback to that. So when wanting to be a catalyst for change and wanting to advocate for something like racism as a public health crisis, you have to add up the cost.
Thank you. That's true. And a lot of times the cost is our own personal stress as we kind of maneuver these different lanes, different ways, bringing these ideas to people's level of awareness that maybe never had to deal with these kind of issues before. So I know that takes a lot of strength, and try to go home and put on a totally another face and try to make it better for tomorrow. So we want to talk about, you did mention implicit bias, Lilliann, and I know us at the American Lung Association have gone through a pretty broad and intentional training about implicit bias just recently. It's Dr. Ukoha just said in a previous segment that he equated it to racism, which I thought was very interesting. But Dr. Ukoha, this question is for you. What can be done to encourage healthcare practitioners to explore their own implicit biases? And we all have those, no matter what you look like. But what are some of your ideas, maybe as you work, especially as we call Cook County a safety net hospital, where I'm sure many of your colleagues I'm hoping have a lot of diversity, but that still comes with implicit bias. Any thoughts on that?
I think I have a slide that follows that question. Okay, here we are. So, implicit bias is one of those. It's not one of those things that's talked about in the hallways of most healthcare institutions, because every focus is on quality. Can you hear me?
Yes, we hear you.
Yeah. Okay. So every focus is on quality and patient care, because that's where the ratings come from, right? To grade your hospital, you have to have, almost impeccable quality and patient care. So the driver for the work that people do is to make sure that those don't fall by the wayside. Now, something like bias, is not anyone's top priority, but it should be, because the environment we're working in is changing. So, just practicing a couple of patient-centered care, helps. It has two important areas: communication and understanding. And I'm talking now to the members of the healthcare team, okay, what you can do to fight implicit bias. You can begin with communication, show respect to the patient, listen to what they have to tell you, and be empathetic, okay? Because they come from various backgrounds, they have many issues, as I mentioned before, And failure to be empathetic doesn't give you the patience to even go through what their needs might be. So communication is extremely important. Okay, understanding each patient's specific needs so that you know how to deal with each one of them is important. So embracing these two items is a dramatic and quick impact in the way that we relate to our patients. Microaggression. Microaggression is what happens when you actually say something to somebody that makes them feel bad about themselves. You know, that sometimes happens openly, where patients are devalued by the words that we speak, to make them feel worse than they are. Microinequity is when you assume that somebody is what they are not. I come into your office with an HMO insurance, right? You assume I'm poor because of that. How do you know that I am poor because I have HMO insurance? What if I chose the HMO insurance for other reasons? And then if you start treating me poorly because you think I have the inferior insurance, that's implicit bias. Okay. So you have to be able to meet people where they are, where they belong. Okay. Don't prejudge them. Don't say something bad about them. Listen to them. Communicate. Okay. And practice microaffirmation. Practice saying or doing something to the patient that makes them feel good about themselves. Even though they may not, you may not, be speaking the truth, but all of us would love to have, positive reinforcement every once in a while, even if it's false. So try as much as possible to practice that. Okay, make your patients feel better. Okay, and I think those are the things that healthcare professionals can at least begin to work with, that hopefully will eliminate the implicit bias that we see in the workplace. And finally, it will help if the administration can embrace this, okay, and provide educational platforms for the members of the healthcare team to understand implicit bias, just as they work very hard to make sure that the patient quality and safety part is accounted for, and then obviously hold people accountable for not practicing those.
I would like to add to that if possible.
Go ahead, please.
So I appreciate these definitions that really speak to cultural humility and the beginnings of one social justice and racial justice journey around implicit bias. When thinking about healthcare system, a physician and a patient is a part of an ecosystem. There's, again, leadership and administration. And I think many times in my experience, working in local government and working in clinical and academic settings, management training is not a priority. And really comprehensively understanding racial justice and social justice and those elements within institutions is looked over. So I would like to recommend that folks look into Race Forward's leadership training around racial justice and the Management Center Managing to Change the World as a BIPOC person, in addition to other management trainings for those that don't identify as BIPOC, but particularly with that training, one examines first how they internalize oppression and how they internalize dominance and how traditions and preferences and requirements can be conflated and what that means to show up and create equity and center equity in meetings and HR policies. And then recommendations from the article from the Campaign Against Racism is that there are 3 practices that healthcare providers can take on in this current window of opportunity to advance racial equity, and that is to think of care over control, have an anti-racism analysis, and to do meaningful community building.
Thank you, Lilliann. That kind of brings a whole nother aspect to management that I don't necessarily remember learning in public health school. And when I was getting my MPH and doctorate, but I think those are all real critical things that we need to bring into general management courses as we, see more diverse workforces, and definitely in regards to our patient populations and the communities that we serve. So I think we want to look and see if there's any, Reggie, do we have any questions in the chat at this time?
I believe we are good to go to the next section.
Okay. I will then hand it over to my other illustrious colleague in putting this wonderful event together, Ms. Alexander. She will facilitate the next section and lead us in final thoughts. Candace.
Yes, thank you, Dr. Fuller. What recommendations would you offer cities, counties, or states that may be considering a similar declaration? And we'll offer this to you, Ms. Paine.
Yes, I'll expound on the care over controlled anti-racism analysis and meaningful community building. So when thinking of care over control, we can look at the pandemic as an example of our surveillance tools. And thinking of the first year of the pandemic, the origin of it, politicians' positions on prevention and the spread of it, and then how that was racialized. And then also thinking of life prior to the pandemic, people like to speak of the healthcare system being broken or that safety net programs weren't fully funded. And that was brought to light in the pandemic. So that compounded effect of lack of investment or resources that could support those that were most vulnerable being amplified in the pandemic, and then adding surveillance to it. So thinking of the at-home orders and those that may have not been able to comply because they needed to go to work, or those that needed to go to work but didn't have transportation or tested positive and couldn't stay home. So when thinking of personal protective equipment and how that was dispersed and who had access to it first and who could afford to keep it, just as we are now with the mass ordinances that are letting up, thinking of what that means and how it shows up differently for resource communities and under-resourced communities. So thinking of the care as you think of how to prevent. And then with an anti-racism analysis, at the beginning of time, as we started out with the definition of systemic racism, having a foundation of white supremacy, and those that may believe that that's fact, and those that don't necessarily have that school of thought, and examining how outcomes are looked at as black and white, and giving space to what it means to disaggregate data and think of what that granular level data means for populations that aren't always welcomed or received or are easy to tell the story of using traditional surveillance systems, and also keeping in mind that it's important to utilize racial equity toolkits. For example, in Milwaukee with the budget, after a year of trying it on and trying it out, there was a surplus. So when you use, I think the term is targeted universalism. So helping those most vulnerable, you're helping lift up everyone. That's an example of how to have an anti-racism analysis that impacts health outcomes. And then meaningful community building. It's great that politicians show up when it's close for people to vote in like their primary elections that some cities and states are going through right now. But what does that engagement look like when it's not time to vote? And what does that engagement look like when it's not budget season? And what does that engagement look like when it's time for performance reviews? So getting to know those you serve and identifying ways that you show up or take up space, and how that is fair and how that is just, and what it means to hold space and be psychologically safe. I think it's also important that people read the original resolution. It's a great first step to declare racism a public health crisis, but when you think of the entity that you are declaring, like if it's municipality, if it's a school system, what are you subscribing to the definition of racism that's listed in the declaration? Are you doing an internal racial equity assessment of your policies and plans of work and bylaws, not skipping the steps that are listed in the original resolution?
And it certainly sounds like all of these reasons have always been there, but the COVID environment certainly amplified the need for consideration of an anti-racist analysis and consideration for a declaration. Yeah,
Yes.
thank you. Thank you for offering us so much in response to that question. Next slide, please. So, what do you think the long-term vision of these declarations might be? And what is the ideal world we're working towards? And how do these things help us to get there? And again, Ms. Paine.
Okay. I think big picture, and I try to reimagine, and working closely with the Campaign Against Racism with Dr. Kamar Jones, there was space to do that. And what we talked about in the manuscript is about truth and reconciliation, addressing Indigenous erasure, and decolonizing data, and also thinking of abolition. So one long-term effect of all those wonderful things, an example of that is the Breathe Act. So that's a project of the Movement for Black Lives, and it calls for the decriminalization, elimination of police enforcement, but is not limited to activities of drug use and possession or loitering or traffic violation. It's a diversion of funds from law enforcement agencies to community-based programs that address violence and harm, as a tangible example. And then thinking of incarceration as a public health crisis, and honoring movements like Give Our Land Back for our Indigenous peoples.
Yes, yes. I want to extend this question also, or at least offer Dr. Ukoha an opportunity to respond or offer some reflections from his perspective as a healthcare worker.
Yes, the ideal world obviously would be one where every patient, every family has access to healthcare. And the healthcare meets the needs of the patient where they should. Not some of it, but where they should. And as I said before, we keep talking about what we can and cannot afford. And I'm here to say that, that should not be the limiting factor. That should be the barrier from moving forward in providing healthcare to people who need them. The form that is going to come in is the question. Would the Congress, or state government, would the Congress have the wherewithal to understand this, understand that access to healthcare is killing people? Lack of access to healthcare is damaging lives. Will they understand it and do whatever they can to eliminate it? Can we eliminate it? Of course we can. Is it going to cost us something? Yes, it will. But it's tolerable if we don't judge it. The only barrier to what we're able to do is we constantly keep judging it. Okay? They're getting free healthcare because they're lazy and they're sitting on their butt. Okay? Don't judge it. Just provide it. Because when you don't, there's a problem. Taking care of people who are at risk for disease is a moral obligation. This society is so advanced when you compare it to the rest of the world that, something like that, so crucial to people's survival, that's missing, is a stain, and a burden for everyone. So what is the ideal world? ideal world is having healthcare offered or present to anybody who can afford it, regardless of what their background is. And can we achieve it? Yes, we can.
Yes, thank you. Thank you. Yeah, I think the, operative thought is that, for those of us who can make a difference, who are in a position to make a difference, need to see the risk in it for us for not doing so, for sure. Thank you.
Thanks.
Okay, next question, and Dr. Ukoha, this one will direct to you. What can clinicians do to move us towards this vision specifically?
Okay, well, we're talking about the vision of providing healthcare to all. Lillian, is that your impression?
Yes.
Okay, all right. So
I'm in agreement with healthcare for all.
So, clinicians, one thing they certainly can do is remember why they got into this in the first place. You got into this to provide care to those who need it. And, when you take your practice away from a neighborhood that is dying for you and to another because of reimbursement, you just left, to waste, people that have no other way of obtaining health care. So, or at least jeopardizing the ability to obtain health care easily. So we have to understand the mission that, makes us clinicians, and the Socratic oath, what that meant and how we need to go out and actually practice it. I said before that sometimes the environment that we practice in and the difficulties that we encounter make it difficult for us to make these decisions. You have family to feed. You cannot just continue to provide care and get nothing back in return. At some point, return on investment of your time and effort, should be something, because you spent your entire life, oftentimes the best part of your life, getting ready for this. And then you come out and all you end up is, working late hours and bringing nothing home. So somebody has to be able to make sure that that situation doesn't exist. It may not be in the hands of the clinicians. It may be in the hands of the government, the local community, or the administration, so that people don't get frustrated and leave because they can't afford to take care of these patients. So I think that what clinicians can do to move us towards this vision is to at least understand the problem, okay, which is, we need to take care of these people at whatever means, with whatever cost, and we need to put our efforts into it. We need to generate the resources as a group. It may not be something that only you can do, but with the administration, community engagement, government, we'll be able to at least address it instead of allowing it to fester like this.
Yes.
I would like to add that in addition to what the good doctor has shared, that clinicians be courageous and take on the American Medical Association strategic plan to embed racial equity and advance health equity. And it's an organizational strategic plan that just came out recently, and it speaks to what the good doctor has said, and it provides frameworks for implementation to do just that, move the vision forward for racial equity and health equity.
Thank you, Ms. Paine, for adding that additional thought. As you mentioned earlier, leadership matters. Yes. So next question, what actions can our audience take to expand equity within their own communities? And whoever would like to go first, and we'll give you both an opportunity to respond.
Well, hopefully over the past 70 minutes, the audience has come to appreciate the challenges that we face and the challenges that underserved communities face. And first, you need to understand that the patients who have these problems are in a bind. And if they are your relatives, you should check in. Okay, you have the technological advancement and wherewithal to help them. They don't have it. It was past their time when these things came along. Hospitals are offering portals to them. Portals are an extremely important way of communicating with the hospital. They don't know how to navigate it. Okay, recertifying or reapplication for all these programs, they don't understand it. Okay, so if they're yours, don't leave them to struggle with these things. Check in with them from time to time and help them, fill out these forms or get to their portal and share the information with them. So you can help expand, at least eliminate some of these barriers that the patients face if they're yours. Now, within every community, you can understand what the problem is. And you know that politicians are the ones that make the decisions or pass the ordinances that lead to the decisions that end up affecting people. Pay attention. Listen to what they have to say. Vote. Okay. Look for the candidates who can best improve your neighborhood. Okay. Don't fall into the trap of listening to those who give you empty promises. All right. So you can change the community by getting engaged. Okay. It doesn't mean that you have to be out there, past midnight talking about engagement. Engagement is just listening to what they have to say and being able to understand it and maybe, rally people around so that when it's time to make the decision, a good one will be made. You can pick the right people to help build your neighborhood. Neighborhood can be built in so many ways. Okay. There are not very many renowned, health centers in underserved neighborhoods. They're all elsewhere, okay? And so how can you attract those? How can you attract, grocery stores? How can you attract, parks and recreation? How can you make sure that, when a plan is being drawn for an area that all these things are taken into consideration, including green spaces, so when you get involved and you realize that failure to address these little things end up becoming a healthcare problem, a few years down the road, and if you don't pay attention to who is representing you, you will send somebody out there who's actually working against you, doesn't allow us to expand this equity problem that we're dealing with.
Yes, yes. Civic engagement is so important, and the education that it requires. Thank you, Dr. Ukoha. Ms. Paine.
Just to tie a bow on what all has been said, I think that it's important for the audience to think of ways that they can foster pathways to truth, racial healing, reconciliation, and transformation. I know sometimes in public health and healthcare, folks get exhausted and want to do all the things at the same time to address all the things because they need it. So to reconcile past harms is important, not to dismiss them, and to create space and training opportunities to have the knowledge of public health and structural and social drivers for health inequities, and to think of how oppressions intersect, and that it's important when doing that. So when thinking of how someone is positioned, politically positioned, ethnically positioned, their gender identity and sexual identity, their education, you cannot not include those things when creating policies, a consensus process, and then thinking of models of improving service.
Yes, yes. Mm. You've certainly given us a lot to consider here. Reggie,
It's a life's journey. It's a life's journey. And I
yes.
think part of it is accepting, at least what I've come to the conclusion of, is that I might not see a lot of this stuff in my lifetime. I can see the beginnings of it and I can plant seeds. But I hope that, you know, as elders say, wait your turn, that my turn doesn't pass me by, and that when my turn is over, that I move out the way.
Yes. Well, I think to date, you've certainly taken advantage of your turn, and I don't believe that it's over for sure. Reggie, do we have any final audience questions?
Yes, we do. I just want to first reiterate, for those of you who are in attendance, please feel free to put in all of your questions in the Q&A box. There are 2 speech bubbles and one of them has a question mark on it. And it should be, I believe, up top for you all on the panel. First question, so there were a lot of resources that were shared. Is there a way we can get a list of those that were mentioned during this call that can be broadly shared to participants? I know that that's one of the questions, is that they weren't able to write them all down in time.
I'm happy to share the things I referenced.
Fabulous. And then I have another question, and this is going back to lung cancer and kind of a part 2 of the first question we had asked, and it's about radon. And you know, we know that radon is one of the leading causes for lung cancer. It's not the leading cause, but it is very high up there, I believe, second. And this person has mentioned that, you know, the radon risk message is not focused enough on Black Americans and for Black Americans. What is it that we can do to improve upon that?
Well, you know, you are right. Radon is the second most common cause of lung cancer. It's odorless, colorless gas that you don't even know exists. So it's extremely important that radon monitoring of neighborhoods exists. You know, so we can certainly handle that with our municipalities. Just like when, you know, you purchase a home and you screen it for radon, we should make sure that you know, every Black family or individual that's purchasing a home gets that radon report. And you know, every so often there is a report about radon from especially the communities where the Black people live. Make sure that it's still falling below the worrisome range, you know, for those who live there. We don't address it as much. You understand radon when you're buying a home, if somebody is able to share that information with you. I don't think that they all get it, you know. So we have to take it more seriously and monitor it. So that's clearly one thing that we can do.
Great, thank you so much. I'm not seeing any other questions in the Q&A currently. I know there's somebody who has their hand raised. Unfortunately, we're unable to mute you. So we encourage you to please put your questions in the Q&A box.
Okay. Is anything popping up, Reggie?
No, there is not. So for those of you, you know, apologies if you're unable. Oh, we just got another one. Great.
Okay. So another question is popping up. Is that what you're saying?
It is more of a comment. I think we can move on to closing thoughts.
Okay. Well, certainly this has been a very rich conversation, and one that we hope that each of you who are joining us today will continue. There's a quote I'd like to offer that I think is quite auspicious for this conversation we've just had. It's by Robert F. Kennedy. He said, "Every time we turn our heads the other way, when we see the law flouted, when we tolerate what we know to be wrong, when we close our eyes and ears to the corrupt because we're too busy or too frightened to do otherwise, when we fail to speak up and speak out, we strike a blow against freedom and decency and justice. So we'd like to invite you all to commit to fight racism wherever you find it, in all the places where we live and play, where we work, heal, and worship, including within ourselves, no matter how hard, no matter how uncomfortable, because action is the only remedy for all of us. As Dr. Ukoha said, this crisis is such that it begs for action. So on behalf of the American Lung Association, I'd like to thank our panelists, Ms. Lilliann Paine and Dr. Ukoha, for their amazing and helpful insights during this conversation today, and to each of you for what you had to offer and for showing up to participate in this timely and meaningful discussion. If you have further questions, feel free to submit them into our Q&A box, and we thank you all for attending. Have a wonderful day.